Good morning. Welcome to this Wednesday morning webinar. This morning we're going to talk about anesthesia and surgery. How are we going to reduce pain and anxiety in kids before surgery? I know that in the audience today we have parents. Welcome. I know we have healthcare providers. Welcome. We typically have a child like this in the morning of surgery. This is a typical 3-year-old child. They look kind of okay, except when you look into the eyes, as you can see, this child is shy, scared. Now take this child and put them in this operating room. And this operating room is actually empty right now. It's 7 a.m. But imagine this room now full of activities, darker, with noises. How do you think your child will react? Well, they may react this way, okay? And in this particular case, we have a child who is holding the mask. And when a child goes to sleep, typically we do it through mask induction, and that means that they are taking the mask on their mouth and they will just fall asleep, and this child obviously is very happy. On the other hand, we may have cases like this, and this is a case where we have 2 anesthesiologists and a parent, and a child who was brought into the operating room and was asked to sit on the table, and obviously this child is scared and in fear. And the only choice they have at this time point is to really just put the mask on the face of the child. We may have a case like this, and this is a child who was brought into the operating room and is now hugging his mom, refusing to sit on the bed. And once the child did have the surgery, we're moving on to the recovery room. And in the recovery room, we have this child who was treated for pain, but is still obviously is anxious and is suffering. So the first question I'm going to ask is, so what if children are upset before surgery? I mean, I have 2 daughters. I can tell you they were upset on their first day in school. In fact, one of them just went to college, and I can tell you she was upset on the first day in college. And I think the answer has to be within this context. Evidence-based medicine. What is the evidence to treat children in a certain way? Disease outcomes. So this crying and anxiety and pain, is it something that just happens for 10 seconds and goes away? Or is it something that actually has an impact? And system outcomes. How are the system designed to minimize the first 2? So let's first start about, is this an important phenomena? Is this crying before surgery? Is being upset? Is this pain important or not? And so this first publication comes by David Vernon from 1967. And he was the first to demonstrate that children who undergo anesthesia and surgery, up to 2 weeks after surgery, have behavioral changes. What does that mean? It means that kids who did not have stranger's anxiety anymore now have stranger's anxiety. It means that kids who did control their bodily functions now don't. Now they pee at night. This observation was repeated in studies at 2006 and in 2007. And all these studies showed that if kids is undergoing anesthesia and surgery, and I'm talking now outpatient basic surgery, there are some behavioral changes in them that go away, mostly within 2 weeks after surgery. But let's talk specifically about this child. Here's another example of a child who did not get any anxiety management before surgery, and so he's about to lie on the bed and he's very unhappy, and so have to hold the mask on their face. We call this stormy inductions, and this is a graph that demonstrates what happens to kids 2 weeks after surgery, up to 2 weeks after surgery, in a child who had an induction which is peaceful, or in a child who had an induction that is very stormy. And as you can see on day 2, up to 70% of the kids who had this stormy induction have behavioral changes. And about 30% of the kids who had calm inductions have behavioral changes. We see the same phenomenon day 2, 3, and 1 week. By week 2, it looks the same. So obviously, it is an important outcome. What else? We did research at Yale, where I was previously. And in that research, we have put actigraphs. And actigraphs are essentially accelerometers. And think about an actigraph as a small iPhone. This is the size of an ectograph from about 5, 7, 8 years ago. Now they're even smaller. It is a quarter. So you put this on kids and then you measure their sleep. 3 nights before surgery, as you can see, before the child went to sleep, there is a lot of activity and then the child is sleeping, occasionally moving during the night. 2 nights before surgery, the same thing. 1 night before surgery, as you can see, movement a bit more. And by the way, this child had an early morning surgery because, as you can see, they woke up very early. And then the first night after surgery, you can see how many times did this child wake up. So every black spike is the child was awake. Post-op day 1, post-op day 2, post-operative day, and post-operative day 3, things are getting back to normal. So certainly using actigraphy, we have shown that if a child is anxious after surgery and before surgery, you see that they are awake at night. Is there any way to treat this sleeping and behavioral changes? So I'm jumping a little bit into treatment here, but this is a randomized controlled trial. And in this randomized controlled trial, one group of children got midazolam, and midazolam is a benzodiazepine. It's also Versed, and you give it to the kids about half an hour before surgery, and they drink it, and half of the group did not get it. And what we wanted to see is, if you give this benzodiazepine, which reduces anxiety and decreases memory, will that impact their behavioral changes? And as you can see here, on the y-axis, you have the percentage of kids with behavioral changes, and here you have post-operative 2, post-operative day 3, post-operative day 7, and guess what? The group that got midazolam had significantly less behavioral changes as compared to the group that got control or placebo. So is there a way to reduce these behavioral changes in children? Well, there are some ways we'll talk about later on, but certainly giving them a sedative has been shown to reduce their anxiety. Now, this particular study looked at children who undergo tonsillectomy and adrenalectomy. So taking a child's tonsil out is probably the most common surgery in the United States in children, although the incidence of that or the frequency of that goes down. And in this particular case, we wanted to see if the anxiety of children before surgery is predictive of what happens after surgery. In other words, do kids who are more anxious before surgery do worse after surgery? And as you can see by these two graphs, the top line are the kids who were very anxious before surgery. And as you can see in all three of them, the kids who were more anxious before surgery slept less well after surgery. And eating improvements, you can see that the kids who were more anxious before surgery improved less after surgery. So this is to say that the more anxious the child is before surgery, the more their recovery is impaired, delayed after surgery. And therefore, it's important to manage their anxiety before surgery. Adults, by the way, are not that different. And in adults, there have been studies. This particular study is from our study group, and it was published in Journal of Psychometric Research at 2000. And in this study, we looked at women undergoing hysterectomy. And we have shown that the more the women were anxious before surgery, the more they were in pain after surgery. Same phenomena. We have seen this in a population of kids. The more they're anxious before surgery, the more they're in pain after surgery. So by now, I hope you're convinced. And you're convinced that what? A, that kids are anxious and cry before surgery. In fact, up to 54% of them do. That being anxious and painful before surgery, being anxious before surgery is bad. A, because it's hardship on the child and hardship on the parent. And B, because later on you will have more pain. Later on you will require more analgesics in the recovery room and on the floor. And you will be discharged later. And in addition to that, later on you'll have these behavioral changes that mostly go away, but some of them can remain for many months later on. So if you are convinced, and I hope you are, then we need to move on and say, okay, what can we do to fix all this? So one of the ways that we can fix it is bring parents into the operating room, right? So it's a very common technique. And in fact, we bring parents into many other medical procedures. We bring parents into bone marrow biopsies, lumbar punctures, starting IVs, resuscitations. So parents in the operating room is not really dramatic. The challenge is that if you bring parents into the operating room, sometimes it's going to work. And here is a beautiful induction of anesthesia. You have a mother who is very engaged with the child. The child is sleeping in the mother's lap. Now the next step is to put the mask on. The child will fall asleep, and everything is very harmonious. But you have seen this picture. And in this picture, the mother is here as well. So I will submit to you that it's not just if the parent is in the operating room or not. It's more complex than that. What does the parent do? What does the environment do to the child, in addition to the question of if the parent is in the operating room or not? This happens to be the topic of a National Institute of Health grant that we have been conducted for the past 8 years. Started at Yale, and now it's continued here at UC Irvine Health. And conducted right now, the second phase of it is conducted at CHOC Children's Hospital. It's conducted at CHLA, Children's Hospital of Los Angeles, Stanford. And I have 4 sites. I lost one. Yeah, I think I said, and Colorado Children's Hospital, 4 sites. Sorry, Colorado, I don't want to insult anybody. And what we're basically saying is the following. There is a behavior from the healthcare providers. There is parents' behavior. There is child's behavior. All this is when the child goes to sleep, okay? That will affect the post-operative recovery. Everybody agrees with that. And what we can see and what we are saying is that some moderating variables such as ethnicity and coping and personality that affects this triad. But let's just focus about this triad right now. Let's just think about how does behavior changes child's anxiety. I'll give you an example, okay, before we actually dive into it. If you're a parent, you know that your child is running frequently, and if they fall down and scratch their head, there are a couple of responses to that. One is to run over to them and say, "Oh my God, what happened? It's bleeding. What are we going to do?" What do you think your child is going to do? They're probably going to be more upset and crying, versus an approach which, "Oh, what happened? Well, let me take a look at it. Oh, that's just a couple of scratches. Let's go and put something on it. It's going to be painful, but it's fine, and we're going to fix it." The 2 approaches will result in very different among the kids. And I know it sounds intuitive to you. So let's move on with that. We took all this data from 330 parents, children, and healthcare providers. We fed it into this very sophisticated statistical program. And we looked at what's called sequential analysis. And we tried to analyze the behavioral interactions between the healthcare provider, the child, and the parent. And we tried to study the relationship and try and determine what leads to what. And we studied the variety of ages. As you can see, this is an older child. And in the background, you actually see how to decode it. And in each one of these, by the way, each induction is about 3 minutes, and it takes about 3 hours to code. It's a very long process that the National Institute of Health was kind enough to help us with or provide the funding. So this is what we found. We found that there are specific behaviors that are what we call desired behaviors, and there are behaviors that are undesired behaviors. So, what are desired behaviors? Distracting. So when the child is undergoing this anxiety-provoking induction of anesthesia, or when the child is in the recovery room, if you distract them, you talk to them about, I talk about basketball games, I talk about pets, I talk about the last birthday party. Anything that will distract the child is good. Anything that has humor and jokes in it. Be funny. I know an outstanding anesthesiologist from Vermont who for years, he was a clown. And, well, obviously an amateur clown. He was an outstanding anesthesiologist, and he used to make coins disappear from the kid's ears. So make the kid comfortable with you. And then reinterpretation means you give the child the anesthesia mask and you say, "Hey, this is an astronaut mask now. Put it on. Now you're an astronaut. Now play with it. What don't we want to do? Well, we don't want to have reassurance. Reassurance means that you tell the child frequently, it's okay. It's okay. The challenge is that we tend to say this to kids from early age. And when a child hears it's okay, that means they better start worrying because they didn't have a chance to worry enough before. That's a trigger. It's okay is a trigger to a child. Start worrying. The second thing is empathy. Empathy is very important when you have an established relationship with the child and it's for a longer period. Empathy for somebody who doesn't know the child makes the child focus even more internally into themselves. So ideally, you rather not have it. Apologies. I am sorry. So, I've had parents who sit there in the operating room and apologize to the child. I'm really sorry I have to do this to you. Guess what's going to happen to that child? And implied control, so asking a child, are you ready to put the mask on? When you know that it doesn't matter what the answer is going to be, we will have to put the mask on, is not realistic. Asking the child, do you want to go to the bathroom? Probably not a good idea because he's not coming back. So give the child control over what you can give them control. Now, we have done a randomized control trial with this here at UCLA, and we have shown that this is working, and we changed the behaviors of anesthesiologists, and the kids became better. And now, as I said, we are doing it at Chalk Children's, CHLA, Colorado, and Stanford, and we randomized them, and we're in the middle of a 5-year study, but we're fairly confident that these are the behaviors that people need or do not need to display. So my suggestion is to look at this entire way of how to treat kids in a family-centered way. A child is part of a family. When they come to have surgery, it's not the child by himself or by herself. It's the child and the brothers and the sisters and the parents. And you have to look at everything the same way. So you have to look at, did the child have surgery before or not? That's very important. If the child had surgery before, it doesn't mean yet anything because some kids had surgery before, had a very good experience, and so now they're going to be very comfortable. Some kids had very bad experience, and now they're going to be even more crying. So find out exactly what happened. In fact, I can tell you that the best predictor of how a child will behave when they walk into the operating room is, how did the child do before? The second thing is, how anxious is this child? And based on that, we can decide in the preoperative period, what are we going to do for this child? We can bring them for a preoperative visit, which means you bring the child to the hospital a few days before, or you do a web-based, which I'll explain in a second, and you tell them what's going to happen. So at least now they know what's going to happen. You can give them sedative medication. The most common one right now, as I said, is midazolam or Versed. So that's a pharmacological intervention. You can let the parent in, which is a good intervention, as long as you tell the parents what to do. Because just letting the parent in, as we have seen, we may have not an impact, and in fact, the kids may be even more anxious. So you really have to tell the parents what to do. There's some other interventions we're not going to talk about, but there are other in the literature. So for example, the work that Dr. Wang from Yale has done has shown that you can treat with acupuncture. If you reduce the anxiety of the parent with acupuncture, actually the child will be calmer, amazingly enough. That's because the parent is calmer, and there is a very close correlation between the child and the parent. Post-operatively, I strongly encourage parents to go into the recovery room. The parent needs to be involved in the recovery room. They need to be there when the child wakes up. They need to communicate with the child. And I would say again, when you communicate with a child, remember the good behaviors versus the not good behaviors. Well, I wouldn't say not good. I would say the good behaviors versus behaviors that are not as promoting coping and promoting more distress, right? So communicate, ask, humor, distraction, reinterpretation, all good stuff. Don't get too much into let the child get into himself and thinks about the pain and anxiety. Um, this, if you can zoom enough in your computers to see this, if not, it is actually in this article. You can find it on the web, Family-Centered Pediatric Perioperative Care. The first author is Jill McCartney, who's right now at Halifax. She's an outstanding pediatric psychologist, and you can find this information there. But basically here it says, recognize that the family is the constant in the child whenever perioperative personnel are available. Facilitate professional collaboration between the parent and the healthcare provider. So it's all about working together with the child in the center. Recognize the family's strengths and individuality. So for example, some parents really believe in alternative medicine. That's great. That's a strength. So you need to talk with the parents and say, that's wonderful. I know that you know there are some alternative ways to manage pain. We would just also recommend you, however, to use the pharmacological ways that there are to manage pain as well. So find the right balance between the two of them. Some families have this notion that any opioids, any narcotic after surgery at home is dangerous because it's going to make the child stop breathing. That is really not the case. And you always need to check the dose and double check the dose. But the dosages that are prescribed are safe dosages, and the child will not become an addict. And as we have seen, it's more important to manage pain than not. Share complete and unbiased information with parents. It is very important to talk to parents and tell them everything about this procedure. Total transparency. And understand and incorporate the development needs of kids. So obviously, until the age of about 9 months, kids typically don't have separation anxiety. So that means you don't have to worry too much about it. Between the ages of 9 months and 12 months, they develop separation anxiety. That's kind of the peak. Then, starting at the age of 3, the kids develop enough to start understand more. So that leaves the age from 9 months to 3 years that the kids are perhaps most vulnerable from the perspective of how do I communicate with them about surgery and about pain. And those are the ages sometimes we need to focus on. One of the ways to introduce the child and the family for surgery is web-based interventions. This intervention right now was just developed with the NIH. It's called WebTips. It is not available yet to the general public, but it will be in the next few months. And the idea here is that since most hospitals right now do not have the parent and kids come before the day of surgery, we can do it on the web, just like we do this webinar. Except this is way more interactive, it's way funnier, and you actually have a site and a child site and a parent site, and you go through this. So in other words, I'm strongly advocating bringing IT and media into this world. And by the way, if the child wants to go into surgery with their iPhone, with the iPad, watching movies, phenomenal. That's just wonderful. That has been shown repeatedly that anything that will distract the child while you put the mask on is great. So don't take everything away from them as they walk into the operating room. You know, give them the toys they like, give them the iPad they like, and let them play with it. Let's talk for another minute or two about pain. So this particular study was done on pain of children undergoing tonsillectomy. And what you can see here is that this is the proportion of kids who rated themselves as significant pain. And if you look at day, let's focus on when they're at home. If you look at day 2, almost 80% of the kids rated themselves as they're having significant pain. Now what's really interesting is if you look at day 2 and you see that almost 80% of the kids have significant pain. On the other hand, if you look at this, it says the number of doses that those kids got at post-operative day 2. And as you can see, almost 30% of the kids did not get any post-operative analgesics at all. Another 15% got 1 dose, and about 20% got 2 doses. So remember how 80% of the kids said that they have significant pain? Well, how come 40% get no medication or 1 dose? So we obviously have a significant issue with under-medicating the kids and not providing good analgesia for the child after surgery. I'm almost done, and then we'll answer questions. But before I'm done, I really wanted to address this issue. I know it's a very hot issue. People talk about it frequently. And the question is anesthesia dangerous to the brain of infants and young children undergoing surgery? If we summarize the topic in 1 minute or less, we can say that there are evidence in animal studies that show that exposure to anesthetics in large doses for long periods of time will cause changes, anatomical changes in the brain. We don't know what it means. We just don't. And if you look at those studies and try to extrapolate for them to adults studies, I should say to human studies or neonates, first of all, the dosage that have been used for the animal studies are not what we use for kids and neonates. They're far, far, far higher. Also, the length of time that those animals got exposed is way, way, way longer than a typical anesthetic. So you can't really just take that data and extrapolate it into neonates. You just can't. There are a number of studies now on the way to look at it in neonates. But I would say, as a pediatric anesthesiologist for many, many years, I don't think that this is relevant. I think that if the child needs to have surgery, they need to have surgery. And I would look at things epidemiologically. Anesthetics have been around now for 70, 80 years. We think that the 6 million kids that undergo anesthesia a year are, if I can use the term, forgive me, stupider than the other kids. I think that after 80 years, we could have seen it. And at least with the kids I see around me, the kids today are smarter than the kids in the past. So I don't think we have a real phenomena on our hand. With that, I am going to stop. And I'm going to encourage you to answer or ask any questions you may have about the topic. I am going to take a couple of questions already. The first question is, when is the best time to talk with a child about anesthesia and surgery? I would say it depends on the age of the child. If a child is older than the age of 4 or 5, I would say the earlier the better, because they have more time to process and then they have more time to prepare themselves. The young kids, ages 1 and 2, don't have yet the ability to process that much information. And so for them, the day before surgery is actually just fine. For the very young kids, the more you talk about it, a few days before surgery, the more their anxiety increases because they can't process the information. So it's really kind of age dependent. The one thing I'm going to emphasize is please talk to the kids. You know, we had a number of incidences in my past where kids came to have surgery and they just didn't know why they're here. And it was very difficult in the morning of surgery to have a discussion with the child and explain to them why they're having surgery and what's wrong with them. So we have to think about that. And we're back. Next question. As a parent, how can we be sure that our children are receiving safe anesthesia? Well, what I would say is that anesthesia today is as safe as flying in an airplane. Now, I do know that we had the disaster with the Malaysian Airlines, but aviation is so safe. It's 1 death to every 250,000 experiences, okay? And so it is about 1 to 10,000 chance to get hit when you cross the street. It is about 1 to 250,000 if something bad happens during anesthesia. So I would say anesthesia is safe, very healthy kids. Now, of course, if the child is sick, situations are much more complicated. I got a question just now here about pet therapy. I would say I'm a great advocate of pet therapy. I think pet therapy is a wonderful thing. Um, in the operating room, it's a bit more complicated. You can't obviously bring the pet into the operating room because of obvious issues. However, I would say in the recovery room, at home, it's wonderful. I think it's just a wonderful therapy, and I know many hospitals that are using it, and I am really all for it. Is there one anesthetic that is better than other for children? I would say that probably not. There's a variety of anesthetics that can be used, and a variety of drugs that can be used. And I would really let your anesthesiologist to choose that because they probably need to make sure that they give the right drug to the right child to the right surgery. It's not as simple as there is one drug that's best. It depends on the condition of the child and the reason for the surgery. What are some of the warning signs of fear and anxiety that you can identify in children before and after surgery? All the research we have done has essentially indicated that children who are very fearful, we call them shy and inhibited before surgery, are the kids who are in a higher risk group after surgery. And you as a parent know that. And so I can tell you as an anesthesiologist, if you see a child walking with their mother into the operating room and the child grabs the parent's leg, you know that that child is more anxious. And you know that it is probably better to manage the anxiety of that child actively. And it's probably better to give that child something. You can give them midazolam, you can let the parents in and tell the parents what to do, you can give them to play with the iPad. There are a variety of methods, but please do something because the child will be just more anxious. How can you minimize negative behavioral changes in outcome post-operatively? What I would say is that the more you're focused on reduction of anxiety before surgery and after surgery, the better you'll do with improving the post-operative outcomes. But at the end of the day, a lot of it is inherent to the child, a lot of it. So please don't think that if the child had started not controlling the bowels after surgery, that it's your fault as a parent because you didn't do enough to control the anxiety. If they are shy and inhibited, they may just do that. The one thing to remember is that 99% of all of these will go away within 2 weeks. If it doesn't go away within 2 weeks, please contact your pediatrician, who will then refer you to a psychologist or a psychiatrist just to see what happened. Did a phenomena such as PTSD just happen? Again, very rare. I mean, throughout my career, I've gotten probably about 20 to 25 emails describing these things. So I know it happens. It doesn't happen that often. So please don't let me alarm you. You discussed some of the target behavior for anesthesiologists in the OR. Can you recommend some target behaviors for the parents? What I would say is it's the same target behaviors that you have for the anesthesiologist. Humor, distraction, reinterpretation, and as a parent, you can do even better than the healthcare provider because the healthcare provider may not know that you had a clown party 3 days ago. So keep on talking, keep on engaging the child, keep on telling them about things that happened in the past, keep on distracting them, tell them jokes. I would say the first thing as a parent is decrease your anxiety. Now, I know it's easier said than done, and I'm going to tell you that when my child had surgery, actually my wife went in with my child because she's the calmer between the two of us, and I let her go in, and my child did great. But you really need to identify the dyad of child and of the two parents. Okay, which parent is a bit more controlling in terms of their emotions, and let that parent go in and let that parent display the behaviors that you want to display. I got another question about music therapy. Music therapy has been shown repeatedly in adults and pediatric studies to reduce anxiety. Now, within the operating room itself, it's a bit tricky because, again, you bring it into the operating room, so what are we going to exactly do? Now, I can tell you, if you're going to let the child listen to music, we have done these experiments in adults, their anxiety will decrease. If you bring in a music therapist, it really depends on the music therapist. Some music therapists had phenomenal results, some did not. But as overall, I would say that the treatment of depression and anxiety with music therapy goes back all the way to the Bible days. And apparently David suffered from some depression, and there are some descriptions of music to allay his depression. So this is an old treatment. It's a very good treatment, and we strongly recommend it. We know children take cue for their family. Can you give us some advice on how parents, siblings, and family members can deal with fear, anxiety, and stress about the upcoming surgery? What I would say is find out from parents what is their experience overall, and then try and through that manage this. So if the parents tell you, you know, I had a labor epidural and it was horrible. It was painful and everything. So in those situations, what I would say is train the parent to really talk about positive things. If the parent had very positive reactions, train them to talk about positive reactions. Next question. Do these theories apply to teens? Absolutely. Teens are young adults. I know that even an 8-year-old now considers themselves a teen, or preteen, The reality is that adults need this advice as well. All of us are anxious before surgery. There's nothing, The big difference is that teens tend to internalize. So you will look at somebody, and with a young child, they're crying, they're struggling, you know that they are in distress. With teens, you don't know that they're in distress. It's all locked in them. So you need to assume that it's there, and you need to manage their anxiety the same way. And you know your teenager. If they're open and if they talk about things, wonderful. Talk about them. Talk to them. Explain to them. I should say talk with them, not to them. Explain what's going to happen. Explain the process. Give them control. Give them advice. If your teen is one who is more closed, try and talk to them as much as you can. They will absorb some of it, and I strongly recommend to treat them for this regard as the same issues that we have with kids. Are there any limitations on what you bring from home to bring comfort, pre-surgery, stuffed toys, and blankets? What I would say is, A, the answer is no. B, just be reasonable. The ORs is a sterile place, and it's pretty confined. So if your child just got a 7-foot stuffed bear, I'd probably leave it at home. But any other stuffed animals, iPads, comfort toys, please bring them in. The more you bring in, the better the child will react to the environment. So I thank to whoever sent me these questions. That is very good. Are there any side effects from anesthesia particular to kids? What I would say is the side effects of drugs related to anesthesia are the same side effects in adults and kids. No difference. That said, kids overall have less physiological reservoir in them as compared to adults. So when something goes wrong in a child, it goes wrong faster than in adults. That is why you have a subspecialty within anesthesiology that is called pediatric anesthesiologist. And if you have them, that's great. If you don't, that's okay. Adult anesthesiologists who have done kids for many years and who have done many kids know what they're doing. I would trust them. And so The kids just need more particular attention. So the drop of oxygen in the blood is faster in kids as compared to adults. And so you need to know how to manage these things in an expeditious manner and pay more attention to those things than in adults. I'm almost done here. I don't see any new questions. So unless you guys will send me a new question in the next minute, we're going to wrap it up. I'm just going to conclude by saying that it is a very important topic. When I started first my training in pediatric anesthesia at Boston Children's Hospital many years ago, the topic of pain was significantly underdeveloped. I remember one of my mentors there, Dr. Charles Birdie, used to sleep in the hospital along with Dr. Neville Setna every other night to cover the pain service for children. I remember Dr. Birdie has to testify in front of Congress that kids actually do have pain, because at that time people saw that kids' nervous system is not developed enough, so they don't have pain. Today we know that that is absolutely not true. Today we know that if anything, kids experience more pain. And today we know that pain also affects the neurobehavioral development of the brain. Some work that was done by Dr. Sani Anand from Arkansas Children's Hospital has shown that. So it is exceedingly important right now to manage the anxiety of pain in children. It is not just managing the moment, it is really managing their neurobehavioral outcomes. Since we don't have any new questions, I'm going to leave you with this last figure here. Thank you, and please don't speak this afternoon, and hopefully you have a dog that can mimic this. But it has been a pleasure to talk to you, and I hope to see you in our webinar next time. Thank you.